everybody. I am Professor Monica Chaudhary from Ansal University. I welcome you all onto the series of these educational panels which have been there going on since 15th April. Lot of appreciations and feedbacks and experts have also been brought in this forum. And today we have one of the best experts here talking on LASIK. Dr. Umang Mathur, who's a senior ophthalmologist, very reputed, and his name is known everywhere. He is the executive director and senior consultant in Shroff Charity Eye Hospital. He is a cornea, cataract, and LASIK specialist. He has many international and national presentations and publications. We also know him that he's operated our Honorable Abdul Kalam Ji's cataract surgery. We know him as a good friend of optometry, and he's always been here willing to be training and teaching us. A wonderful human being. I welcome you, Dr. Umang. And among us is another very big reputed name. I think it needs no introduction, but still we would request Ajit ji to introduce him.
Well, thank you, Monica, for giving me an opportunity to introduce my most favorite optometrist in the country, the person who is most successful as far as the profession goes, and I've been following him from last 45 years. I came to know Vipinji when I joined AIMS in 1976. He passed out in 1977, and immediately he passed out, he joined as executive director, or you can say the executive optometrist, because he was always executively most prominently dressed optometrist I have seen in my career. Coming back, in 1982, he established his own center, his own clinic by name of Low Vision Aid Center, which was in South Extension. Later he moved, that was in his residence. Later he moved to his South Extension market, and now he practices in Lajpat Nagar, and he has a multi-specialty clinic, which he has the LASIK, he has the contact lenses, he has spectacle correction, and that is what he told me. But what I've seen more about him is that he has over the time innovated optometry. Not just he stick to the normal profession of prescribing glasses, but he went on to today he has specialty contact lenses he practices. He is the only person in the country who have, a dry eye clinic which has, lip view, lip flow, and I think among optometrists he is the first one, and maybe among ophthalmologists too is the first one. Maybe, pardon me if I'm wrong, but to my knowledge, he has established all specialty of optometry, including binocular vision treatment, including vision therapy, LASIK. He has been upgrading his clinic from time to time, starting from, Dr. Umang will talk about various LASIKs, and that's what he will mention. But what I want to tell you is just that over the years, he has been the icon of the optical industry. Coming back, if I go back, when he started in 1982 from his own house, he created, trends in the profession. If I go back, he was the first person to come to, in the Delhi market to launch soft contact lenses. He taught us how to handle contact lenses. The times we were just struggling to fit hard and rigid contact lenses, he moved on to soft one and introduced those contact lenses from, I think, his friend from Darius, Bombay, and that's the lenses which were most popular in those days. When we were struggling with the glasses, use of glasses, he was the first one to introduce resilience in Delhi market. When ophthalmology was just doing normal cataract surgery, he was the first one to bring IOLs and specialized good IOLs to Delhi market. One thing I have seen is this, that when other people join the same business, he moves out and establishes a new trend in eye care and optometry, and that has been his, his hallmark, or his the way of doing business. What I learned that, because of his contacts and because of his good work in optometry, he is the only healthcare professional I know who has been the optometrist to the President of India for not one, two, but 7 consecutive presidents have been his patients, and he has been serving on their panel as the optometrist. In 30th of March 2000, when he was just 45 years of age, he was conferred with Padmashree Award, which is very, very rare to find at a young age of 45. Well, ladies and gentlemen, when I was looking at all his credentials and I've been watchful of what he has been doing, I'll tell you, I will request each and every optometry student or even practicing optometrist to take out their pen and paper. And the way I will give you the things insight into him, how he has achieved these and those qualities of his management of business, management of practice optometry. Basic is something, but the way he has grown up, the way he has modeled his career, that is something what you all need to see. And I will mention few qualities of him which I have watched closely. Number one quality which I have seen him in since the time he was a student, his immaculate dress sense. He has been always the most dressed person anywhere, whether it is his clinic, whether it's a party, whether he goes out socially. He is the best dressed person I have come across. Number two, quality number two, his ability to reach to patients. I was privileged to drive down to Dehradun. We were arranging a conference with him, a contactless conference in Missouri, and I happened to go with him. And when we finished the work, we saw the hotel, and after finishing, it was just 12 o'clock. We thought we'll be back in Delhi 5 o'clock. But he said he has to meet few friends. I said, fine, sir, just go ahead. And I was surprised to see the number of circle of patients, which he called them as friend, were so many, and he was carrying special gift for everyone. That made me to think, we call them as a patient, and he tend to create them, not tend to create them, but he creates them as a part of the family. Wherever we went, we were treated like a family. And that's something we need to learn when we try to think of being in a profession which needs so much of personal attention. Then I thought more. I said, what else he does differently? Look at his stationery, his logo, the way he writes, the way he sends you a letter, the way he communicates on every platform is different from the rest of the world. I have not seen any optometrist in India, anywhere in the world, or maybe any other healthcare professional being too much careful about how he communicates to people. And that is something you need to see in all his communications. And every optometrist learn to see how you create that difference from the rest of the people around you. I'll come back to some of the more qualities which I've seen in him. The way he connects to his friends. You know, we all think of Deepavali. For last 15, 20 years, his favorite cake reaches me the first, and not only me, but many other doctors, many other of his friends. We are the first one to wake up. Okay, now we have got Diwali cake from Buckshey, Diwali aane wali hai. And that's the way we start cleaning of our houses. And that's something he does so differently and makes us think, take us granted, we never even reciprocate and tell him thank you because we have just grown up eating those cakes which you send it to us. And that's something which we need to learn how we connect to your friends. One thing I tell you, we get WhatsApp forwards for this message, that message, how are you in Corona, this and that. But he was the only friend who called me to find out how I'm keeping. And that's what makes a difference, because WhatsApp, if you look at the SMSs you look at, is something which you get every day. But a personal message from a friend, from somebody whom you least expect, is something that keeps him different, out of the league. One more quality what I see him in him, the way he keeps his relationship. In last 45 years, there were times we are now I'm his junior, but we develop a kind of relation, and in that relation sometimes there are some misunderstanding. There was a misunderstanding between me and him, and one day he called me. He said, sir, I'm coming to have a lunch with you. And the way he said, there's no way you can say no. We said, we had lunch. He's very fond of Chinese food, the way I know it. And we had lunch and we clarified the misunderstanding. And then that makes the bond stronger. and stronger, because he has that quality of making you feel most important person in his life. Ladies and gentlemen, I've never seen a person, a, an optometrist. Not only he is not envied by optometrists, we all are following your career, the way you have risen up. And the last and the most important quality what I've seen, I've observed in him, is his willingness to help. I'll share you my own experience. When I was starting my own business, I was struggling with my finances. After doing my interiors, I had no money to buy the furnitures, fixtures, and I went to him and he told me, take my table, take my counter, take this chair, take that chair. I picked up everything from him, every instrument, because he was moving from Southex residence to his Southex market. He gave me everything and he didn't ask me any penny. And one day I asked when I had a bit of money, he said, no, this is my gift. This is my blessing to you. I want you to do well in life. Ladies and gentlemen, it's impossible to find a friend, to find a guide, to find an optometrist like him in this country and the rest of the world. I have met people all over, but he is something unique. And that is what I told Monica, that I need this. Normally she does all the introduction, but I requested her, I will do this. And it's our honor that the person you admire most is sitting next to you. Thank you, sir, for taking our effort and be here. Appreciate.
I think we endorse that all. In fact, there are
Yes,
many more
of course.
qualities which you must have
Yes,
missed, but I think
absolutely.
the seminar will end up with that. Thank you so much.
The topic is something else. But this is just the beginning. You will see more what he's doing for optometry and for LASIK in time to come. Thank you so much. Over to, I think Dr. Umang will have a presentation and then.
Yes. So we will begin with Dr. Umang first, because one of the common conceptions, sir, is that everybody is hearing all these kind of names in different LASIKs, and the patient, while refraction, has questions and wants to know more from us. It's the concepts which have to be very clear in LASIK, because optometrist is the first line who talks to this patient. So over to you, Dr. Umang, for the presentation.
Thank you so much. And at the outset, thank you for the introduction and inviting me into the optometry group. And my entire LASIK journey has been with Vipinji, and I cannot second enough what Ajit Bharadwajji said about Vipinji. I think he is an exceptional human being, and I'm privileged to be a colleague with him. So I will be talking of all these different types of LASIK you hear about, and what are the different refractive surgeries available, and how each one of them has a role, and they can complement each other in taking care of the patient. So the important thing, of course, is always to choose the right patient. And who's the right patient? It could be a person who's getting ready to get married, or it could be a stud like this guy who wears spectacles don't support his physique. And it could be somebody for a profession, that some professions require where spectacles become a hindrance, or just a lifestyle thing. And all of these people respond differently. And guess who will be the easiest, who's not going to be difficult to do surgery on, and who will be the most problematic, who's going to jump the most during surgery. And you'll be surprised, this guy over here, he is going to be the person who's jumping the most. He may look like a very well-built, muscular chap, but inside he most likely would be a very weak guy. So you need to understand the needs of different people. What if somebody is going to be in combat? What would be the best surgery for him? Somebody who just needs it for a lifestyle change. Somebody who's over 40, what would be the surgery you'd suggest? For high hyperopia, what would be the right one? We need to understand that. You also need to do a good slit lamp examination. We don't want to miss out dry eye because LASIK would induce a little dryness for a few months. And so a slit lamp examination would be important to look at any signs of dryness. Some of these epithelial dystrophies, which may be asymptomatic to start with, but post LASIK, they may have healing problems and they may have loose epithelium for some time and can become troublesome. So we need to know what would be the best procedure for them. Blood vessels sometimes can be a problem, especially in chronic contact lens users. They may cause bleeding and interfere a little bit. Pupil size is important because a lot of photopsias, glare at night, and all those issues can come if the pupil is very large. Fortunately, most Indians have a pretty small pupils, and so this kind of a problem is not very frequent. And of course, myopes especially are at risk of retinal detachments. They may have degenerations in the periphery, which the LASIK per se may not cause a problem, but it's good to do a good indirect ophthalmoscopy to rule out any kind of lesion because the patient may otherwise come back and say it's the LASIK that caused it. Now, the decision making that we have to do is between these different choices of procedures that we have available. You can do a surface ablation, of which photorefractive keratectomy is the commonest. A variant of that is LASIK or epi-LASIK, but they are generally just fancier terms for the same thing, and you don't really need a lot of fancy equipment because finally it doesn't change the outcome. So PRK is usually the commonest procedure performed. Then you have the standard LASIK. One can have customized LASIK. You could do a femtosecond LASIK. You could do a surface ablation with mitomycin C. Then you have the implantable contact lens or ICL. You could do a refractive lens exchange, which is essentially a clear lens extraction. And then the newer modalities of LASIK extra or PRK extra. So we'll study these different modalities a little bit today. Now in surface ablation, this was the first procedure that came up when excimer laser came in. And here basically you do it under topical anesthesia and you, with a hockey stick instrument, you remove the surface epithelium. Now if you can put a little alcohol to loosen the epithelium, or even if you put Paracane and leave it in a well for about 30 seconds, that also loosens the epithelium. And you debride the epithelium about 8 millimeter kind of diameter. And then on the dry surface, the laser works and flattens the cornea for myopia and peripheral flattening so that the central cornea steepens and hyperopia. And then you place a bandage contact lens on the eye, because as we know, whenever we remove the epithelium, there's a lot of watering, there's a lot of pain. And to reduce the pain, we put a bandage contact lens. Now, how you remove the epithelium, it could be with a mechanical, just a little instrument. Mechanically, you can remove it. You can put alcohol and that loosens the bonds with the basement epithelium, makes it easier to remove. There are some fancier rotatory brushes. You could even remove it with the excimer laser. There's a bluish hue that comes as long as the epithelium is getting removed. And after that, once that stops, you're on the stroba. And then there is an instrument like a microkeratome, by which if you do, it's called LASIK. So these are different methods, but essentially the outcomes remain the same, whichever way you remove the epithelium, because the epithelium, as we know, regrows, and it's the same outcome that you may have. So you really don't need anything fancy, and you use the excimer laser to correct the number. Now, PRK, of course, the most important thing is that for 3-4 days, the patient may have significant discomfort. That is because it takes about 3 days in most people for the epithelium to come back. And even with the bandage contact lens, the patient may have discomfort. We've also seen that these contact lens sometimes binds to the eye, and that binding of the contact lens also causes pain. So for 3 days, we see the patient daily. Without the epithelium, there's a risk of infection as well. And you have to manage pain during this time. So we give oral analgesics, cold compressors help. If you have a contact lens, if it gets tight, becomes a problem. So sometimes we put a lubricant and move the lens a little. So the first few days, you have to manage pain and you have to safeguard against infection. And it's good to see the patient daily for the first 3 days. One problem that comes subsequently is that in higher numbers, if you're doing ablation for anything over 4-5 diopters, some patients, especially those who are aggressive healers, and higher the number, which means that you have ablated more, you can have haze on the cornea. And that's why PRK patients need to be under close observation. So after the initial healing also, for the first 8 to 9 months, you must see the patient every month. And the first thing that would happen is that there's a little regression. So the patient may be 6/6 and has become 6/9. And if you refract, you find there's a small number that the patient may get. And that would be a sign of regression. Regression can be with or without this kind of haze. So initial haze, if you step up the steroids, you can reverse the process. So there's a lot of modulation that is required with topical steroids in these patients. Also during surgery, anything over say 1.5 or 2 diopters when we treat, we put mitomycin C on the cornea. So after we've done the excimer laser, we take a sponge and immerse it in mitomycin C and put it for something like between 10 to 20 seconds, depending on the number, and then wash it thoroughly. Mitomycin C also decreases the fibroblastic activity and reduces the scarring. So PRK patients need counseling for this problem to happen. Those that have good follow-ups and in lower numbers do very well. Also, nobody can tell on slit lamp examination whether you've had this procedure. So some of the candidates who don't want to reveal that they have had refractive surgery, they can conceal it with this. But most importantly, because you're not losing tissue in the flap, you save between 100 to 150 microns. So if you're a borderline cornea, say 480 micron, and you have to correct 4 diopters, or 460 microns and 4 diopters, while the rest of the topography is okay, it may be safer to do a PRK than doing a LASIK procedure. And so there is a subset of patients whom we do PRK on. In my practice, it would be about 10 to 15% of our patients still get a PRK. And that is because if they are thin corneas and at risk of ectasia, I would prefer doing the PRK, but these patients I keep much closer follow-up and they need counseling that they have to tide over the initial period of pain. And it may take about 10 days for the vision to stabilize. So unlike a LASIK who's happy within a few hours, a PRK patient may take a little time to normalize. Now, LASIK is the most popular cornea refractive procedure. The full form, of course, is laser in situ keratomileusis. We were initially doing pretty high numbers. We would do even up to 14, 15 diopters. And if we had enough tissue, we would go ahead and ablate as much as we could. Subsequently, we realized, and sometimes we may still do it up to about 10 diopters, that if you're doing higher than 10 diopters, a lot of cases will have some regression. So higher numbers, you find over a period of few months, some of the numbers starts coming back. And also it causes more photopsias. The patients the contrast sensitivity may get affected. So about 10 diopters is what my limit is, 8 to 10 diopters. Over that, I would be a little reluctant to do a LASIK procedure. One can do now correction for astigmatism, pretty good correction you can get. Hyperopia also, karne ko you can go up to 8 diopters or so, but maybe up to about 6 diopters. So these are conservative numbers. One could stretch it to about -10 or maybe up to +6, +7. Over that, also it's possible the machine can correct, except that you may be causing a lot of distortion of the cornea. Now, in LASIK, what we do is the standard LASIK is done with an instrument called microkeratome, which makes the flap. And different instruments make the flap superior or nasal. The more popular ones, and I personally prefer a superior hinge. So you make a flap, you apply a suction ring, and then you have the microkeratome work over it. And then the laser ablates, and then you put the flap back. So the other method, of course, is we'll talk about is with a femtosecond laser, where you dock this to the laser over the eye, and then the laser makes the flap, and we'll be talking subsequently about it. So a microkeratome basically works by applying a suction ring, and we normally stop doing pachymetry on the table. So you could take an 8.5 or a 9.5 diameter. We take a 9.5 when it's a hyperope or a flat cornea. And then you so you do it on a wet surface. Initially, when you apply the suction, it's on a dry surface. And this microkeratome motor then runs on gears. It's a very powerful motor. And then it comes back. It leaves a superior hinge. And then this lifts up, and then you can do the laser on this. So you dry the bed, and then the laser works, then you can put the flap back. Now, the most important thing in LASIK is the pre-op planning. And the planning is basically the thing that you're most afraid of is developing a keratoconus-like picture called ectasia. So in your planning, you have to see whether you have enough tissue left below the flap that the cornea doesn't become unstable. So that's also during surgery, like I said, you look at what ring to use. In hyperopes, because you're treating the mid-periphery, we take a 9.5 millimeter. And in flatter corneas, we take a larger ring size so that you have a broader hinge, because flat corneas can cause free flaps. Most of the microkeratomes cut between 130 to 160 micron. However, one should be careful when you're using a microkeratome. You could be 20 microns plus or minus. That's the kind of accuracy that a microkeratome may have, about 20 microns plus or minus. So you need to keep enough safeguard when you're doing a microkeratome flap, because, and it's a meniscus flap. That means it is thicker in the periphery and thinner in the center. So that is, but it's almost like a bridge. It's like a suspension bridge. The anterior cornea has fibers like a bridge. So wherever you make it, the weakest part is the thickest part of the flap. And so it cuts thicker in the periphery, and that is around 160 or 180 microns sometimes. And so one has to calculate the bed that you're going to have based on the thickness of the flap. You also should see the pupil size, because you can select the treatment zone from something like 5.25 to about 6.5 millimeter. And sometimes we can give a transition zone. Smaller the zone, the lesser the tissue you need to ablate. So that's the trade-off. If supposing you are 500 microns with a -7 number, if you, most of the machines like the intralays that we use consume around 11 to 12 microns per diopter. So if you have a smaller zone, say about, if you keep 5.5 optical zone, you would need something like 65, 70 microns. But if you keep it at 6.5, you might need up to 90 microns. So if you keep a smaller zone, you need less tissue. However, if the pupil is large, in the evenings, the patient may have glare and halos, and that's the trade-off you are playing around with. You also need to leave enough tissue below. So although you may think that the flap you're putting back, but the thickness of the flap weakens the cornea by that many microns. So you're weakening the cornea in a LASIK by two ways. One is by the ablation that you're going to do. So supposing you take 70 microns out with the excimer laser, and you've used a microkeratome with something like 160, 170 head, then it's 160 plus 70. That is about 230 microns is what you are weakening the cornea. Now, if the patient has a bed of 500 microns, then you're leaving 270 microns. Ideally, initially, most people were happy leaving about 250 microns, but nowadays we would like to leave at least 300 microns. So if you are able to make a thinner flap, then you are saving more tissue and keeping the eye more stable. There are some other formulae which say that leave at least 40% of, don't leave at least 60% of the tissue behind. So even if you have 600 microns, it doesn't mean that you can take away 300 microns. You should leave at least 320 or 340 so that about 60% of the tissue stays back. Then there are different criteria. This is the Rendelman's classification, which says that this side is that you are at higher risk. And as you're leaving more than 300 microns, a younger patient is at higher risk of ectasia, because as you know, if supposing you are a keratoconus patient, we know that it is most affected in the initial years. Over 30, the cornea cross-links itself most of the times, and the progression doesn't come. So if you are at a younger age, you have higher chance of ectasia as compared to older age. If you have corneal thickness to start with less than 450, it's a no-no for LASIK. Over 510, you are much safer. Similarly, the higher the number you correct, the more chances of ectasia. So these are some of the red flags. This zone you would avoid a LASIK procedure because there is a risk of ectasia. Of course, there are criteria based on pentacam and topography that one must be able to read. I'm not talking on pentacam in this lecture. We also look at whether it's a steep cornea. A steep cornea causes buttonholing with a microkeratome. If it's a flat cornea on a microkeratome, there's a higher chance of free flaps. So these are different things that we look at in our pre-op planning and decide which patient would benefit from which procedure. So if it's a very thin cornea, while the topography is okay, and the number is mild to moderate, I might look at a surface ablation. A routine patient, say -5 with a 520 micron, I would prefer doing a LASIK because it's more comfortable and it doesn't have the problem of haze. If it's something like a -7 with a 510, what would we like to do? There, I would go for something like a blade-free LASIK or a femtosecond LASIK. Now, in a femtosecond LASIK, it's the femtosecond, which is 10 to the power of -15. A laser basically makes this is a precise beam of light, and it's a string of lasers which create cavitation bubbles. These tiny bubbles basically disrupt the tissue and create a plane. So the laser first makes a horizontal plane, and then it makes the flap on the side. And you can fashion the hinge whichever way you want. You can move the size of the flap you want. If you want a large flap of 9mm, that's possible. If you want to make it into an 8 or even smaller, that is possible. It can customize your hinge whatever you like. If you want a straight cut or do you want a beveled cut? So a beveled is sometimes better because it sticks much better. So you have a lot of designs to play with. You can even center it on the cornea. So if your centration of the suction ring is not very good, you can center it on the cornea. Even the suction ring is much less. When we do a microkeratome, we apply about 60mm of mercury. Here it is around 30mm of mercury. So a femtosecond laser allows you to make a thinner flap. You can do up to 90 micron flap. And this is a planar flap. So across the cornea, it is of the same thickness. Unlike the microkeratome, which is a meniscus flap, which is thinner in the center, a femtosecond flap is a planar flap. It's uniform. A microkeratome, you're not sure, plus or minus 20 microns. Here it could be plus or minus 2 or 3 microns. So when it says 90, you're pretty much at 90. There's no guesswork, or you don't have to leave that much of margin because it will be 90 microns. So a femtosecond makes it more, so it's a more predictable corneal thickness. So all through it's the same thickness, like I said, within 2 or 3 microns. So you're very sure when you say 90 micron, it's 90 micron. It's not like it could be 70 or it could be 110. And so you can calculate the stroma that you're going to leave behind. Because even the excimer laser can give you up to a decimal of how many microns you are going to ablate. So you can make your calculations mathematically, and you're pretty much sure that what you calculate is what you get. There isn't that risk of abrasions, free flaps, buttonholing. All these things don't happen with a intralaser or a femtosecond flap. So you can actually, I used to do almost 25% surface ablation procedures because in thin corneas you would avoid. But ever since the femtosecond LASIK came, more patients can go in for a LASIK procedure, which is more comfortable with no risk of scarring. The femtosecond flap adheres to the cornea much better. It causes much better adhesions. And so the risk of flap dislocations is much less. And so if you're dealing with a patient, say in the armed forces or police or something, the femtosecond is sometimes a little better than the microkeratome because the adhesion would be better than that of a microkeratome flap. So the risk of dislocation is lower. Then we come to something called a C-LASIK or customized LASIK. Now, if you see the normal cornea is prolate, which is that it is thicker in the periphery and thinner in the center. And the shape is prolate. While when we do a LASIK, we make it oblate, where the center becomes flat. And it can cause a little irregular astigmatism. Now, lower order aberrations are spherical correction and astigmatism. Those are called the lower order aberrations. When we are doing a refraction, we're doing a retinoscopy, you're basically correcting lower order aberrations. However, there are some higher order aberrations, which is what some patients will complain of: streaking, comas, trefoil. All these are higher order aberrations, which cause that, contrast sensitivity difference, glare, photopsias, more difficult to define. Now, there is an instrument called abrometer, which can actually measure your higher order aberrations. So the wavefront guided LASIK basically picks up the image from the abrometer, and from there you take it on a pen drive to the excimer laser based on your refraction, which the abrometer is actually a wonderful autorefractometer. So you can make your small corrections of manifest refraction if required, and you then put it on that pen drive and take it to the excimer laser, and then the laser works according to your surface. And potentially it reduces the aberrations, and so you get much better vision. So this is the abrometer, and you could do a wavefront guided, and some machines give a guided excimer laser. So it can actually give much clearer vision potentially. Also, most of the machines have a better eye tracking mechanism fit on the customized LASIK. So there's iris registration. So most of the trackers in the machine, because the patient's eye moves, it could move in XY movement, and most of the trackers track the pupil and the limbus. So it can measure this way and this way. However, they don't, if you're moving like a torsional movement, that is not picked up by the tracker. Now, if you do an iris registration, which basically picks up the iris pattern when you're in the sitting position and you're doing that on an abrometer, the customized platform takes up the iris registration. So even if you're moving like this, that will track it. So for higher cylindrical numbers, and if you have higher order aberrations, customized LASIK would give clearer vision to the patient. Now, having said that, it came with a lot of excitement, and for several years, we used to push our patients for customized LASIK. However, practically, we didn't see that much of a difference, except for cylindrical numbers for patients who actually exhibit more high order aberrations. The other problem with the customized platform is that it consumes more tissue. So if you want to save tissue in a patient who's borderline, then it's better to do a standard LASIK. Customized LASIK probably gives slightly better vision, but it's something that the patient has, you don't get that kind of feedback from the patient always. Now, there's a term which is getting popular today called Lasik Extra. So this is basically a standard LASIK on a patient who has a high number, say somebody with something like -9 or -10 with 510 or 520 tachymetry. Now, even if you do a femtosecond LASIK, you're making the bed quite thin. Now, in these cases, you want to strengthen the cornea, and after doing the LASIK, you put riboflavin under the flap, and then you cross-link the patient. Or in a patient who may be borderline keratoconus, formifrostic keratoconus, but wants a correction. So nowadays we can do a PRK on them so that you reduce the aberrations, you shift the cone to the center, and do cross-linking with it. So instead of just doing cross-linking, for mild to moderate, maybe up to about 52, 53, something like K reading, if you're a mild to moderate keratoconus, along with the cross-linking, you could touch it up with a PRK. So that you improve the patient's unaided vision or BCVA with glasses. You could combine a PRK, cross-linking with PRK, or in a borderline high myope, borderline thickness, asymmetric topographies, uh, to strengthen the cornea. Along with LASIK, you do cross-linking. So this decreases the risk of post-op LASIK and promotes long-term stability of the refractive error. One more thing that is in the market is called SMILE, or the technical term RELEX, refractive lenticular extraction. This is actually offered right now with the Zeiss platform, and very soon Vizix is going to come out with their own. Here, there's no excimer laser required. The entire surgery is done with one laser, the femtosecond laser, where the laser first makes a horizontal pass, then another horizontal pass above, and then the side one, so that you get a disc. And then it creates a small pocket through which a forceps goes in, and you can remove the lenticule. So you basically dock the patient onto the laser, and 2 layers of horizontal ablation, then vertical ablations. And then through this incision with a forceps, you extract the lenticule. Now, this is what is the SMILE procedure, where you have not made the entire flap. Through a smaller incision, you remove the so it basically, you need one laser. You don't need a microkeratome. So the chances of flap dislocation are less because there's just a small little incision. They say that dryness of the cornea would be less, since you're not severing the corneal nerves 270 degrees, just one small incision. However, a lot of studies have shown that the dryness continues to be similar. Of course, there's less chances of flap misalignment and dislocation, and maybe a little less ectasia since you're not severing that much of corneal tissue. The procedure can sometimes be difficult. The extraction doesn't come out very easily, and so you may have tears on the incision. Sometimes there could be a cap perforation. It takes a little longer for the patient's vision to recover as compared to a eye LASIK or a femtosecond LASIK. It takes a couple of weeks for the vision to stabilize. They are working on it. It's not very good for astigmatism and hyperopic corrections yet, but I think the technology is moving towards it, and slowly those kind of procedures would also be attempted through SMILE. Now, when we are dealing with much higher refractive errors, instead of doing a cornea procedure, we do a lens-based procedure. And there you have 2 choices, a refractive lens exchange or a clear lens extraction, or the other alternative is to do a phakic IUL. Now, refractive lens exchange, the problem is that it doesn't correct the presbyopia. So if you're dealing with somebody over the age of 35, I prefer doing a refractive lens exchange. It's a very physiologic surgery. Basically, you're doing a cataract surgery on a patient whose cataract hasn't come. You're doing a clear lens extraction, and you fix a lens inside the eye. Well tested over time. Millions get cataract surgery every year, and they do quite well. The main problem is near vision, and we sometimes do a mono vision where one eye will leave a small myopia, so that helps in the near work. But the problem is that a lot of the IUL power calculation formulae are imperfect when it goes to that higher myopia. So in hyperopics, again, high hyperopes, refractive lens exchange is quite a good idea. And one could even do a multifocal lenses for hyperopia. And these patients are quite happy because hyperopics are the most unhappy patient because both for distance and near, they need glasses. So hyperopic patients are easier to please. Also, the risk of retinal detachment is negligible. So when you have a high hyperopic patient, usually these patients have shallow anterior chambers and may not be very good candidates for phakic IULs. I like to do clear lens extraction for them with or without a multifocal lens. Phakic IULs, ICL is the commonest procedure that is done today. Here, a lens almost like a contact lens is put just above the crystalline lens behind the iris. Because it can cause a pupillary block, usually we would do a peripheral iridotomy before the surgery. Although nowadays there's a central hole in the lens which can allow aqueous exchange, but still we prefer doing a PI. You must have an anterior chamber depth of above 2.8 millimeters. And this is a simple procedure that can be done under topical anesthesia. So you insert the lens in a cartridge, sorry. And you put a little viscoelastic in the eye. It's done under widely dilated pupil. And a temporal incision is made quite like a phaco incision. And this lens is then just inserted in the eye. You have to take care that the crystalline lens doesn't get damaged. There's about 2 to 5% chance of early cataract formation. And the risk of endothelial damage is very little because this is behind the iris. But intraoperatively, yes, some endothelial damage could take place. And you have to watch for glaucoma as well. A lot of it is dependent on the vaulting of the lens. So pre-operatively, we want to know the K reading, we want to know the refraction, we want to know the anterior chamber depth, we want to know the pachymetry. With all these measurements, the company makes a lens which is customized to the patient. One could have a toric lens as well to take care of the astigmatism. So it first lands over the iris and then you tuck the haptics behind the iris. You could do what we call as bioptics if supposing you have a small error left after ICL or a clear lens extraction. One could still do a Lasik after about 6 weeks to 2 months and correct the residual number. So these are all possible. You could do a piggyback IUL if with a Lasik touch-up. So it is the excimer laser is quite a versatile equipment which can be used for touching up eyes if there's a biometry surprise or there's residual number, and it's very accurate to do that. So with that, I think I'll end the talk. These are the different bouquet of refractive procedures that we have today to choose from. And each one of, it's not and or, each one of them complements the other. And you have to pick and choose what would be the best for the patient. Thank you.
Thank you so much, Dr. Umang. It could not have been any better than this for the kind of audience we have today, all the optometrists, and you have removed away many doubts, so much so that I had made a list of so many questions, out of which 90% you have already answered. Perhaps you were reading our mind to see what we may. There'll be more questions, definitely. I'll first request Padmashree Buckshey to say a few words, say some of the scares which people have in mind. How long will the procedure be? How long will the pain be? Will you bandage my things like that, or whatever you would like to comment on, and then we'll go on with questions and answers. Vipin ji.
Dr. Umang has made a very good presentation, very informative. Sir, I would like you to also talk about the shield you were mentioning, which you have developed for the slit lamp. Dr. Umang has developed a shield and has got it fabricated in his hospital, which every optometrist will require while examining patients during this period. So I request Dr. Umang to just talk 1 minute about the shield which you were mentioning this morning. I can't hear you.
Ollie, please unmute, sir.
Yeah, sorry.
Oh,
So you're talking about the shield to protect on the slit lamp.
exactly.
Yeah. So I think it's critical today that we understand the risks of working with the threat of coronavirus. And as we are seeing with the government, and I think it's the right decision that slowly we need to come out of it. The virus is probably going to be there for several months, and we all have to work and still protect ourselves. So number of steps that we need to do. Maybe in your clinic, you need to get a thermal scanner that you test people with for temperature and only then allow them to come inside. You should be wearing gloves. You should be wearing a good quality mask. It's not necessary in the OPD to use an N95, but a three-ply mask would be good. Must wear gloves. Whoever enters the clinic, either they should wash their hands or should have hand sanitizer available. You can, by law today, refuse a patient who's not wearing a mask to come to enter your clinic, even the attendant. Strictly one attendant per patient. Try to space out your appointments so that there's no crowding, and even the waiting area, ensure that there's social distancing. So ideally, it's better to have single-seater chairs that you can move around and place them in a way that there is, people are not sticking to each other. When it comes to the examination of the patient, you could put an acrylic sheet, which, you just have to make some holes where the eyepieces go. It could even be a transparency or a plastic folder that you get, that you can place there you can just make some holes to put it where the eyepieces are, so that when you're examining the patient, the aerosols from the patient don't come near you. So that sheet helps. Also, see the patient with the mask. Even the patient should be wearing a mask. There's a tendency for patients to pull their mask on as soon as you bring them near the slit lamp. So please insist that they're wearing the mask. Don't speak to the patient while you're doing the slit lamp examination. And it's only when you have done the slit lamp, usually takes about 30 seconds, then you pull back and then start talking. And then clean the slit lamp with spirit or any kind of antiseptic. Same goes for your autorefractometer. So these are things that we all need to work. And over the gloves, if you're using, you could use sterilium. Wash your hands frequently. I think these are things that we'll have to learn to do because this is the new normal.
Thank you.
Vipin.
Yeah.
To start with, I would like to thank Madhur ji, Ajit ji, Monica ji for giving me chance to participate with all of you. Mr. Ajit ji has been very kind with the introduction. I don't deserve such words. Ajit ji is a very good man and a good optometrist, but in the habit of speaking lies. What he said is not correct.
That's for us to decide.
He's a very good man and a very good old friend. As far as the refractive procedures are concerned, optometrists and eye surgeons can work in very close tandem in a very comfortable way. When I started my facility, it was probably one of the first facilities in Delhi. My work was only 30%, 70% of the facility was used by hospitals and eye surgeons. there has been no problem. It has worked as a very comfortable, good team where people have no problem in bringing the patients, doing the patients and bring them for follow-up or whatever they want to do. The facilities there. After me, the 122 machines were put up between Delhi, Noida, and Gurgaon. It is not a business proposition for an independent practitioner to put up a machine. Out of the 122 machines, 46 machines have already closed because it was not independently viable for one practitioner to generate sufficient revenue to sustain the machine. It's an expensive proposition, more than the machine when the warranty of the machine is over. After 1 year, the AMC works out to more than 5 lakh rupees a month. Unless and until you have volumes, you cannot survive. So if you have to build volumes, it has to be a group practice. It has to be a teamwork between hospitals, eye surgeons, and optometrists. We have to create a transparent platform where things are done in a proper scientific manner, the way they are supposed to be. Now, as far as the role of the optometrist in procedures, refractive procedures is concerned, apart from the flap part for which we are not qualified to touch, we can do majority of the work. 70 to 80% work in the refractive procedure can be done by us. The first is that, as Dr. Mathur said, everybody is not a suitable candidate for Lasik. We have to pick and choose the right patient. After doing certain tests like OpScan and all, 15 to 20% patients are rejected on the scanning stage. Once you select a patient, depending on the corneal thickness and the correction required, there are so many questions the patient has. Counseling is a big thing. It takes sometimes even 2 to 3 sittings to convince a patient that this is what they're going to do. And every time they come, sometimes they will come with the mother, with the father, with the uncle. They have so many queries. These are the patients who are not going to pay from their pocket. The decision to get the surgery is not done by them. It is done by their parents or their relatives. So you have to satisfy a number of people. Counseling is a very big thing. Then we come to the pre-operative investigation. Things like OpScan, Pentacam, even checking the pressure. Main thing is no machine, even the best machine in the world will not check the prescription of the eye. The prescription which you feed in is what the machine is going to correct. After the procedure, if there is a residual number or if there's an overcorrection, the patient will not leave. Refraction has to be done not once but 3 to 4 times by 3 or 4 different ways to make sure that we give them the correct number. Patient selection, all the preoperative investigations, refraction, and then we come to the maintenance of the machine, maintenance of the Lasik room. These machines are never switched off. These machines are like premature babies. We have to maintain humidity and temperature 24 hours of the day, 365 days in a year. If your energy levels are more, which is called fluence, if your fluence is high, you will get an overcorrection. If your fluence is low, you will get an undercorrection. In both these conditions, your patient is going to be very unhappy. So maintenance of the machine, proper servicing, proper humidity control, everything, all the flows tests and all has to be done by the optometrist before you start the procedure. Maintaining the machine, maintaining the room condition in post-ops. An optometrist can do it comfortably. I've been doing it for almost 20 years now. So these are all the things where we have to work with the eye surgeons, support them, take their support and work as a team. 70% of the business in America in the refractive is through opticians and optometrists. It's not like saying it's my baby and it's your baby, it is our baby. We can definitely do it.
I can't agree more. I think an optometrist contributes immensely to refractive surgery. And our association with Vipin now it's maybe 20 years that we've been working together. And I think we are a team. We complement each other. in doing this procedure. And optometrists are basically, except for the surgical part, almost everything else is actually done by optometrists.
Exactly.
And having this kind of a facility where different surgeons can come and use the facility, which is well maintained and you get good outcomes. To me, no patient has ever come and asked me, why are you taking me somewhere else and not doing it here? Because they understand that you're taking them to a good center where you promise good outcomes. The patients are looked after well. Having a facility like that is extremely useful for ophthalmologists because, like mentioned by him, it's heavy investment. And unless you have enough volumes, it doesn't justify putting one more machine. And maintaining a good machine, having a good standard of care is a must. It's a machine that requires a lot of care of the right temperature, humidity, maintenance. The laser head has to be maintained. You have to maintain all the standards of asepsis. So outcomes are quite dependent on the facility and the equipment and the technology. It's a relatively easy procedure surgically, but a lot of it, your success depends on choosing the right patient and then executing it well with the right technology, understanding which kind of procedure the patient would work well with, and then executing it well with a well-maintained machine, a good asepsis, and good care, and of course counseling. And so all these factors are important, and optometrists are in a very good position to participate in the care of the patient.
Sir, it's like saying, sir, even the best physician who has hundreds of patients a day cannot put up his own CT scan or an MRI.
Yep.
It has to be at a neutral platform.
Yep.
And the cost of a LASIK machine is not less than any CT scan or MRI.
Right.
After 1 year, when the warranty is over, we have two options. Either we give a service contract. If you give a service contract, the manufacturer will kill you on the parts. Parts are frightfully expensive. So we have no option but to give a gold contract. The gold contract is 60 lakh rupees a year plus GST. When they come to sell you a machine, they will talk all sorts of things. Oh, you get 10 cases and you'll make money. 1,000 eyes per year is your running cost. 1,000 eyes per year is your depreciation of the machine cost. I've changed 4 machines, so I know. After you cross 2,000 eyes a year, that is where you start making whatever you're making. The manufacturer may give you a nice sales talk and give you nice project reports made by big institutions. But 2,000 eyes is your break-even per year. That is the hard reality.
What a statistics.
No, sir, this is my experience I'm talking.
True. What I feel here is, I think you will agree, the refractive surgery is constantly evolving, and this provides a great opportunity for all optometrists for newest technology. And if optometrists will proactively suggest the patient that you can go in for this, they themselves talk. What importantly happens is, one is the patient realizes that it's not a hidden secret that I'll go to someone else to find out this, and this person is ready to cooperate with me about it. So you'll have questions and more referrals can be done, and post-op and pre-op management and total patient care and relationship will grow with the optometrist on such a referral. Vipinji, I'd like you to elaborate a little more on the time it takes from patient entering into completion, how long the bandage lasts, is it painful, things like that the patients often ask.
What we do is, after we do the scan and the patient makes up his or her mind to go in for the procedure, we have to give them pre-operative instructions, like if they're using soft lenses 1 week before, we ask them to stop. If they're using rigid, we take 2 to 3 weeks for them to stop using lenses. 2-3 days before we stop swimming and eye makeup and so on and so forth. 24 hours before we start some antibiotic drops. On the day of the procedure, we ask the patient to keep half a day totally free. It takes about 2 hours at the center because the procedure is only 20 minutes, but we make the patient sit for 45 minutes to 1 hour before we check them on the slit. After that, the instructions to the patient are to go straight home and sleep for a few hours. When they wake up, they are free to start whatever they want, but 4 precautions are to be taken for at least 7 to 10 days. No rubbing, no splashing of water, no eye makeup, no sweat. Basically, the eye is not to be touched. The word which we use in our clinic is, please treat your eyes like 2 premature babies for 7 days.
Thank you. Oli, do we have questions on the other forum, YouTube?
So I think we have taken all the answers. As you rightly mentioned, all the questions are being already answered.
Yeah, I have a question to Dr. Umang. In fact, this is one, and I would like to sum up also some things. There were some questions and chats which we are just merging over. One thing is the apprehension between the optometrist itself. When they do the refraction, they usually fear that I may lose my patient to refractive surgery and not a contact lens. And here is an example sitting here which is trying to show an optometrist which is both refraction, contact lens, and a refractive surgery, all portfolios in together offered by the optometrist. And I think Vipinji is a real role model to show that, to remove the apprehensions what they have been asking. The second question which is coming up frequently, sir, is about contact lens, so Lasik and refractive surgery complications. People want to know percentage, how safe, and this is the common question which our patients ask, is it a safe procedure? So what should be the way we should communicate to our patients in this case? Dr.
One, there is, if you look at the US, the term they use is co-management. In India, unfortunately, there are all kinds of stupid terms people use as commissions and cuts and very crude way of saying this. It should be done very formally. Like with me and Vipinji, we co-manage our patients. It is all of it is we are very transparent with the patient. What part of the work is done at Visual Aid Center? What part of work is done at Shroff? The patient is not told, he is told everything very clearly that we will be doing the procedure on that facility and who is going to be doing what part. So this is something that as an optometrist, you have done the pre-op evaluation, you've done refraction, you may do a topography or pachymetry or you may not. You could do a keratometry. I think every optometrist can do that. You can do a keratometry. If you can, I would suggest keep a pachymetry. Keratometry, pachymetry, and refractions is generally in 99% of the cases enough to tell you whether you are safe for LASIK or not. Like I said, you need to know these limits. You have to be armed with information. You need to be very confident when you counsel that this is what we are planning to do for you. And like me, you could also go to a center with the patient after counseling and schedule the procedure. And then after the 1 day post-op, where you need to know flap is in place, vision, largely it is lubricants and taking care of the patient's refractive errors and other problems subsequently. So the whole refractive procedure can be very easily co-managed with the center where there's a doctor who would do the procedure. But you need to know which procedure, when you would do, what are the limits. And for that, yes, your next question is kind of linked. You also need to know the pitfalls of the procedure. So for me, there are 3 or 4 things that I always tell the patient. It's almost like a script, that there is a very small chance of an under or over correction, which is very small. Generally, it may be in 2 or 3% patients. But if I'm doing, say, -8, -10, I do tell them there's a small chance of regression. I tell them after 40, they will require reading glasses. I would tell them that for a few weeks, your eyes would be dry and you would need lubricants. And I would tell them that you need to be careful for the first week, 10 days, that you don't splash dirty water, hands into your eye, avoid a head bath. We don't want infections in the eye. And you need to be, as mentioned, soft contact lenses preoperatively, at least for 3 days before the procedure. For RGPs, a little longer. No makeup around the eyes for about 15 days. Avoid swimming maybe for a few weeks. So these are things we say. You don't have to tell them all the possible complications of flap dislocations and epithelial ingrowths and DLKs. That happens in hardly less than 1%. It's good to have these things written down. You could have a small brochure where things are written down for patient to read. But the major ones I would talk of is dryness, and immediately when I talk of dryness, I also say it's temporary. So it's not something that's going to be permanent. For about 6 weeks to 3 months, your eyes may feel a little dry, but it's temporary. You talk of a small under or over correction, which is still you will not need glasses most of the time. In India, fortunately, there are more 20-somethings who get it done. So unko lagta 40 is far away. So you can tell them about near vision issues after 40. And a few little tips on what they need to do post-procedure for a week, 10 days.
Thank you so much, Dr.
Yeah, that's usually what I discuss.
I think those are quite few things. Yeah, so usual question, another which one asks is that in how many days of leave that I'll have to take for this procedure? When can I go back to my work?
So depending on the kind of work, but for most desk workers, I would say 3 to 4 days.
Oh, yes.
So if suppose
at least at a stretch, we can say maximum 1 week.
At best, for most people, if I am operating on Friday, I would tell them you could actually start working on Monday or Tuesday.
There is also a comment which has been coming into the box of questions. There is somebody who says LASIK is permitted in US by the optometrists who do it and many other countries, but in India it is not, I think so. I think that's a comment or a suggestion.
That's a big debate.
Yes, Vipin.
That happens in the US. I think it's to do with also in the US, there are certain states that have allowed it, not across US.
Yes.
Even in India,
we had Dr. Seema the other day. Please go ahead.
Yeah. Even in India, a lot of ophthalmologists don't do it. See, you need for any surgical procedure, you need volumes to be good at it. If you do one surgery in 3 months, would you like to get your eyes done by a person like that? Or would you prefer a person
Vipin, you would like to add to it?
Yeah, absolutely. In the US, only 2 states have given license to optometrists that they can perform these procedures. As far as your first question was concerned, science knows of 3 forms of vision correction: spectacles, contact lens, and LASIK. I would request every optometrist, if possible, to be associated with LASIK also in some way or the other.
Yep.
With my own experience, I can tell you, before I put up a machine in 99, in 98 or 97, whenever patients you would ask me that we have heard that there is something called LASIK, I would say don't get it done. It's still on the research stages. It is not on a firm footing. I will not recommend you at all. I used to meet a few people socially, and when I asked them, you have not come to the clinic for a long time, one lady had the guts to tell me Vipin, you were not well informed. I went to the US and I got it done. I am absolutely. Before the patient goes some, because the patient is very well informed. The world is very small now. Before the patient goes somewhere else, might as well be a part of the procedure. We always had a fear that you will lose a contact lens patient if you recommend LASIK. That's not correct.
And it is so safe today that even currently in my hospital, I have at least 3 ophthalmologists who have got it done. So it's no longer that ophthalmologists are not getting it done. So I think that's the test of the pudding. When knowingly you know what all.
And sir, would you like to comment on ortho-K also? Because orthokeratology is also now a vision correction option. So what is your recommendation or stand on
So I think every
patients who can't get LASIK?
Yeah, so everything, it's not and or. They all complement each other. So orthokeratology, I think, had come a decade back. And then we played around with it a little bit, burnt our hands, and then totally gave up. But I think it's made a resurgence again in the recent years. I think before the age of 18, when you don't want to do LASIK, and somebody doesn't like to wear contacts or is into sports or something, I think orthokeratology is not bad for those. Somebody having a very small number and wants to get himself, cleared for the armed forces or police or something, you could try orthokeratology for that, where for a 0.75, if somebody is getting rejected, you could try that. Somebody who's just generally not wanting to get any procedure, sure, orthokeratology is there. But I think it's a very small subset of teenagers not ready right now because of age.
It's LASIK reject also.
It
is LASIK rejects. LASIK rejects also come back to us.
Corneas, where you could go for orthokeratology. So there is a subset of people. Unfortunately, cost is not one of them because the cost is similar. So it is not because of cost that somebody would go for orthokeratology. I think it is a very small subset of people who are LASIK rejects or underage or things like that, where orthokeratology can be offered.
Especially in that age group where they are not fit for LASIK.
Yeah.
We do only LASIK after 18, 19, and when there's a history of a stable refraction.
In fact, one of the research papers says that if teenagers who are wanting to get LASIK and they've been refused, shifted to orthokeratology, rather US and others, the trend is this. They put them onto orthokeratology, and somebody who's enjoyed the life without the spectacle and contact lens, the moment they get into that LASIK age criteria, they are the first ones to go and opt for LASIK then, even in this. Yeah. There is some question which is on presbyopia and LASIK, and any options on that, and what is in for presbyopes also in terms of LASIK?
You have the option of a monovision after LASIK. So when we do the workup, we put a pair of contact lenses and show to the patient that these are the options which are available. You want total distance, you want one distance, 1 year, or you want one distance and one intermediate. The intermediate will take care of your mobile and your watch. But for fine print, you will still require glasses. You have to show all these options to the patient by putting on single-use contact lenses, and then let the patient decide what he or she wants. Dr. Umang will tell better about this.
No, I would agree. Unfortunately, we don't have very good surgical solutions for presbyopia. So I still feel this is what I would do. I mean, use a contact lens to simulate, what kind of vision they would have. If you get full correction for distance, what happens to your near? Then you put a contact lens which has, say, 0.75 or whatever for near, and how that helps. Because sometimes it's hard for patients to suddenly understand one eye for distance and one for near, and they think you're crazy or something. So simulating it on a contact lens really helps them understand what they're going in for. So as of now, I think that's probably the best option. Sometimes Vipinji can play around with the laser and make a presbyopic cornea, corrected cornea. So those are his artistry that he does on the cornea with the laser. That also helps to some extent.
And in my experience, I've seen monovision is only successful with people who are virtually spectacle haters. They are willing not to read, but they don't want to get it. In such cases, especially in Bollywood and all, it's been a very good success. One eye is working for distance, one eye is working for reading. You must be doing the same for intraoculars also after that, right?
Yeah, we do that.
Yes, Monica, anything?
I think some connection. Let me ask the next question which came to the forum to Dr. Umang sir. What effect does Bowman's layer have on post LASIK, especially on surface ablation procedure? Traditionally, it's being stroma that involved. What about this one?
So LASIK is below the Bowman's. So when you're making the flap, you're below the Bowman's, so you're not ablating the Bowman's. But when you're doing a surface ablation, the laser ablates the Bowman's, and what is said is the keratocytes, the cells in the cornea get excited, and that inflammation causes the scarring. So breach in the Bowman's membrane is sometimes the inciting factor for it. So we don't know perfectly well that role, but in surface ablation, some of the keratocyte activation happens because of breach in the Bowman's membrane. So that's something that, and that's why that risk of scarring is there. And we generally put mitomycin C on the cornea when we're doing a PRK. But unlike a LASIK, who is doing well in the first week, even if you don't have a follow-up, you'll be generally fine. But a PRK patient, you need to follow up that patient every month for almost the first year. And you have to modulate your steroids. Some high numbers when I do, I might give steroids for almost 6 months or 8 months in tapering dosage, monitor the intraocular pressures, see them regularly, because you don't want that haze coming. If you pick it up early with steroids, you can reverse it.
I think there are enough of questions and things in minds and everybody. It was such a wonderful session. In fact, the kind of presentation you have done is a big resource for us, our students, and the whole fraternity. We thoroughly enjoyed, and we had wonderful teachers today teaching us. It was such a beautiful lecture. I think we would go back to you, Ajit sir, again. Yes, you started the show, you end up the show.
Okay, thank you everyone. I want to tell you some insight into it. You know, out of all the procedures in the body, after plastic surgery, LASIK surgery comes at number 2. It is the most emerging surgery in today's time. And when we look at the trends in myopia, by 2050, half of the world will be myopic. If you out of those, 10% will have high myopia. Even if you look at the prevalence of high myopia today in our population, we have 2% of patients who have high myopia. Optometrists need to understand that they have a collaborative role and a co-management role in today's time, which is very, very essential. You know, most of the opticians, most of the optometrists get, very narrow-minded, thinking that if they refuse or if they give a bad opinion about the LASIK, patients will not get it done. But times have changed. Patients are well informed. Today, it's a time to collaborate with good team of optometrists, team of ophthalmologists who work collaboratively to make that co-management possible. You know, out of 3 machines, there are recent surveys that out of every 3 LASIK installed, 1 is closed within few years. So the platform idea of us holding this with Vipinji and Dr. Umang is not that to encourage you to get into an instrument like LASIK, but idea is to collaborate with existing successful practices which are prevalent in today's time. We don't have any financial, commitment or financial gain in this, But what I'm suggesting is collaborate with right people, collaborate, look at the history of. I see a lot of advertisement for LASIK coming on. I have never seen a single advertisement coming from Visual Aid Center about LASIK or any other procedure. That suggests that this center works on word of mouth. Word of mouth is a way when all the existing patients are satisfied and there is an opportunity for one patient to become your ambassador, and that's what I have seen with them happening. What I would request everyone to get into it, to be a part of co-management team with them, with others in your city. You can get a kind of good. I was talking, we were holding a seminar with Dr. Natarajan from Mumbai, and he within after 2 webinars, he said that I have already hired an MBA to work out with the franchising arrangement. What Dr. Mathur said very rightly, we use a very cheap terminology like commissions and all. When you establish, just like what Dr. Mathur said, that if we install just a small keratometer and a pachymeter and do a good refraction, counsel the patient, because you are spending, optometrists have more time to counsel than an ophthalmologist. You have more time, you see more patients coming to you for refractive error than an ophthalmologist may be seeing, because they are busy doing some other work. So you are at the right platform to convince people, and you have to be part of co-management in today's time to survive. There's no much money left in selling contact lenses. I'll be blunt and very frank. What do you make with all the competition going on, with all sales of online contact lenses available, the glasses available? So it's better that you collaborate, develop a practice whereby you are part of the team. I think that's what I would suggest. And that's what our idea of this webinar is. And in my experience, we can't find better partners than Vipin ji and Dr. Umang here. And I would encourage everyone to get connected to them, to connect to us. We will connect to a few. And that is the idea of this presentation. Thank you very much.
Thank you very much.
Very well said. Thank you.
Thank you. Thank you.
Very good day.
Thank you.